Welcome to my A&E talk. Here we discuss everything that is relevant to current A&E practice, and I'm Noel, A&E registrar working at NHS.
Hi there, welcome to Any Talk. Today we're going to look for another article, and this one is also from Emergency Medical Journal, and the article is Prehospital Clinical Signs are a poor indicator of raised intracranial pressure following a traumatic brain injury. So once again, I found this particular topic to be interesting, so I thought we'll have a discussion today. And before we dive into this article, I want to once again make a disclaimer saying this is not a clinical appraisal of this paper. It's just something I found interesting, so I thought we will discuss and get some learning point out of it. This is a retrospective cohort study, and this is by the pre-hospital anesthetic team who attended via air ambulance, and they go to patients who are suspected to have traumatic brain injury, and then they try to find if the patient has any signs of raised ICP using the clinical signs, the traditional clinical signs that we look for, and then they start the treatment right away on the scene before transferring the patient to the hospital. So this paper is saying their reliance on the traditional clinical signs of raised ICP in a traumatic brain injury and their treatment reliant on it, and see whether that has been a good indicator. So that's what this whole study is about, and that's what we're going to dive into and we're going to find out. Before we get into the meat of the paper, I would like to get rid of a few pathophysiology regarding raised ICP before we get into the paper. So here we go. A normal range of ICP varies with age, and values for pediatric population are not well established. A relationship between a volume and a pressure within a cranium is non-linear. What it means is basically a cranium is a fixed compartment. It doesn't expand either outward or inward. So anything that is inside the volume inside the cranium, when the volume increases, the pressure doesn't directly increase according to the amount of volume that increases within the cranium. So even a little bit of a volume increase can shoot up a significant amount of pressure. So that's what it means by a non-linear relationship. Monroe-Kelly hypothesis, that is something you all would have heard of. So here I'm just gonna make it plain and simple what this hypothesis basically means. So as I previously stated, the cranium is a fixed volume. It's a box that doesn't expand. So you have multiple volume compartments and volume of things inside, such as your blood, your brain, your CSF, and a space occupying lesion, a hematoma or tumor or anything. So these share the space within a fixed compartment, which is your cranium. So if there is an increase of one volume in that compartment, the other compartment have to compensate by decreasing their volume or trying to decrease their volume. So let's say the patient has a head injury and they have a developing hematoma. So intracranial blood, especially the venous compartment and the CSF compartment, are the first thing that reacts the moment there is an increased pressure within the cranium. They tend to decrease. So they adapt fast and they decrease immediately in sign of a raised ICP. Once that compensatory mechanism is exhausted, let's say the venous compartment and the CSF can't decrease themselves any further, that's when you have the issue, and that's when there will be a sudden spike in rise in pressure. So a cerebral perfusion pressure is the pressure that needs to be maintained to have an adequate blood flow in your cerebral system. It has a formula, which is MAP, which is your mean arterial pressure minus the intracranial pressure. So the cerebral blood flow is constant over a range of varying cerebral perfusion pressure, and this is due to cerebrovascular autoregulation, where it dilates or constricts accordingly in need now of maintaining a cerebral perfusion pressure in order to maintain an adequate cerebral blood flow. If the autoregulation is impaired, or if there is a change in blood pressure or ICP, they all can affect the cerebral blood flow. So there's a combination of clinical features we look into, or traditionally we look into, as a sign of raised ICP. One such is headache. So this headache would have the red flag symptoms, such as the headache increasing in when you are straining, like coughing or doing exercise or sneezing. So that's a red flag sign of a headache. These headaches tend to be worse in the morning when you get up. The reason being that you're lying down flat, and that impedes the CSF drain. That's why we tend to put them in a 45-degree angle to help with the venous flow and the CSF flow. So that is one reason, one theory given for the reason for headache in the morning. The other one is raised in the carbon dioxide level in the blood, and that is tend to cause vasodilation of the cerebral blood vessels. So again, there is an increase in the venous compartment of the volume in a fixed cranium. So that causes again a headache. And finally, there is also a theory saying there is a decrease in CSF absorption overnight. The other sign we look for is papilledema. But then again, this is a very late sign because it takes several days to develop. But then again, this is one of many signs we look for a raised ICP. And vomiting. Once again, this is a late feature. But none of these clinical features individually or in combination tells the severity or the degree of hypertension. Other clinical features that follows along with it is decrease in GCS. Is theorized because of caudal displacement of diencephalon, that is basically the posterior part of your forebrain and the midbrain. Other signs are pupil dilation, ptosis, impaired upgaze, respiratory irregularities, and these tend to be due to the tentorial or tonsillar herniation. So there is a study by Bullock and the colleagues has concluded a class 2 and class 3 evidence on following recommendation on whom you should be monitoring ICP. So the recommendation 1 says ICP monitoring is appropriate in severe head injuries, that is GCS less than 8 or less, and has an abnormal CT scan. Recommendation 2, ICP monitoring in severe head injuries but has a normal CT. But then again, they should have 2 or more these following clinical features, such as age more than 40, unilateral or bilateral motor weakness, and systolic blood pressure less than 90. The third recommendation is ICP monitoring not indicated in mild and moderate head injuries. And the gold standard we know for monitoring an ICP is an intraventricular fluid-filled catheter transducer. Now we're just going to quickly jump into the pathophysiology of Cushing's triad. That is something we all know what it is, and we know that is also a sign of a raised ICP. So Cushing's reflex is a physiological nervous system response in sign of a raised ICP. The triad itself consists of 3 things. Widened pulse pressure, so there's increase in systolic blood pressure and decrease in diastolic blood pressure, and there is bradycardia and irregular respiration. These 3 things makes the triad. In the first stage of the Cushing's reflex, there is significant rise in blood pressure and tachycardia, and this is to overcome the raised ICP pressure. Remember, the cerebral perfusion pressure is MAP minus ICP. So the simple math is that if you need to have a positive number, well, you need to have that MAP significantly higher than the ICP. So there is a sympathetic activation that happens to overcome the raised ICP. So again, to put it in a simple term, for the brain to be adequately perfused, you need to have that MAP higher than the ICP. In the second stage of Cushing's reflex, the hypertension persists, but the patient becomes bradycardic from tachycardia. There are multiple mechanisms that has been proposed regarding this bradycardia. Some theories say this is because of raised hypertension causes significant dilatation of your baroreceptors, which in turn activates your vagal stimulation and causing your sinus node to fire less, causing the bradycardia. It says that the chemoreceptors outside the brains are not involved, but rather compression of intracranial vagal nerve causing the bradycardia. And in the final stage of the Cushing's reflex, when the herniation sets in due to the raised ICP and the compartment is closed and the brain just literally just herniating out of the cranium, that's when the patient starts to have shallow breathing followed by short periods of apnea. So this is considered as the last stage of the Cushing's reflex. Basically, at the end of the day, all these compensatory mechanism is trying to perfuse the brain, and if you fail to do that and the ICP just tends to raise and we're not able to treat it and the infarct sets in, basically ischemia sets in, and you trying to do things to primarily to decrease the ICP and also trying to prevent secondary brain injury so that you can actually salvage the ischemic penumbrum region. So the penumbrum region is the region that surrounds the ischemic part of the brain where the edema sets in, where the blood level is too low for the brain to function, for to have any electrical activity going on, but the ion channels are still preserved. That is a part that you can still salvage. So going back to the paper, occurs in a time period between 1st of Jan 2016 and 1st of Jan 2018. So the number of patients they looked into is 249. Surprisingly, this paper has showed that there is no optimal cutoff to look for in a Cushing's triad. There is no optimal number given what is your high systolic blood pressure should be, or what is your cutoff for your bradycardia, and what is the amount of pupillary dilatation, the size of pupillary dilatation you need. So this paper made a cutoff for them to look and see whether using a cutoff would increase the sensitivity of these clinical features. So the optimal cutoff they have chosen for systolic blood pressure is more than 160, heart rate less than 60 beats per minute, and pupillary dilatation more than 5 millimeter. So basically the conclusion of this paper is that these clinical features are extremely poor predictors of raised ICP, and they tend to under triage patients. The treatment decision based on these clinical features that was done by the pre-hospital team was correct in 75% of the cases, and they looked into by seeing if that percentage could be improved by keeping an optimal cutoff that I just previously told, and that number didn't change. According to the paper, the specificity of these clinical features in combination was good in finding a raised ICP, but the sensitivity was very poor. And this another paper actually concurs with this finding. Many patients who had raised ICP, midline shift, or a mass effect, or an impending herniation arrived to the hospital undiagnosed. Hence, the sensitivity of using just these clinical features to find raised ICP was poor. So what is the sensitivity that we're talking about? So a highly sensitive test means that it has a few false negative results, meaning there are fewer cases are missed. So what are the reasons for the low sensitivity in this study? So there are a few things that have been proposed by this paper. Pupillary dilatation and Cushing triads are late sign. So you're not going to wait around for that to happen. So that means prior to that, we don't have a good clinical features to look for, modalities to find a raised ICP. If you're going to wait for the pupillary dilatation to happen or Cushing triads to set, it's already late. A significant amount of transtentorial herniation happened in an elderly population, occurred silently without any signs of raised ICP or any red flag clinical features. And finally, a hypovolemic patient cannot develop a Cushing's triad, especially someone who has a hemorrhagic shock. Someone who has a traumatic brain injury tends not always have an isolated brain injury. They have other system multi-organ injuries, and if they bleed out, they can't develop a Cushing's reflex. So hence it causes a false negative cases. According to this paper, 24 out of 206 patients without any clinical signs received hypertonic saline as a treatment process. Why? Maybe the pre-hospital team gave it to them looking at the trend of the vital signs rather than looking for one optimal cutoff. At the same time, 11 with clinical signs of raised ICP did not receive any hypertonic saline. Why? We do not know, because it was not documented. So what does the future hold regarding a pre-hospital setup for them to find a raised ICP? Because we know these clinical features are not of much of any use because of the poor sensitivity, and they always tend to be late features rather than early features to pick up. So there are a couple of things that has been proposed that can be used by the pre-hospital team to increase the sensitivity, or rather to quickly find the raised ICP cases. So one of them is the ocular ultrasound, which is a promising tool in finding raised ICP. And the other one is portable near infrared brain scanners. So ocular ultrasound is something we tend to do in hospital. In a trained hand, it's a very valuable clinical tool. It's fast and easy method to detect it. So basically what you do is you measure the optic nerve sheath diameter, and if it is beyond 5 millimeter, it roughly measures more than 20 millimeter of mercury of intracranial pressure. At the same time, you need to remember, not every patient who has more than 5 millimeter tends to have elevated ICP. This infrared brain scanner that I mentioned prior is completely new to me, and I had to look into it. And this uses a near infrared technology to screen patient to find for intracranial bleeding. That something sounds extremely valuable, and I've never seen one personally or seen one be used, but something I'm going to look into and read more into it. So these two things can actually help a pre-hospital team to find a raised ICP in out-of-hospital setup. Obviously, as any study, this one also has its own limitations. There's few that I'm going to run through quickly. The retrospective character of the study, the selection bias, the breathing pattern was not included as a part of a clinical features when they were looking for raised ICP. This could have aided in the low sensitivity pattern that this paper picked up. At the end of the day, this is a very good paper, and it had quite a lot of learning bites. Something that we need to take into consideration while we practice. So many of these clinical features, these textbooks clinical features that are the red flags for raised ICP, or always tends to be late. So with that in mind, we need to try to look for other methods to increase the sensitivity in us finding these raised ICP. So hope you got something out of this paper, and I am planning to dive deeper into this particular topic in further episodes of A&E Talk. Thank you for joining.